This is Dr. Quinn Capers IV, and I want to welcome you on behalf of the American College of Cardiology to our scientific sessions, and particularly to this industry theater that's going to be focused on diversity and inclusion and how we can partner with our partners in industry to achieve our goals of caring for a more diverse America. So it's critical to our mission, the American College of Cardiology, to enhance diversity throughout the profession of cardiology and in the American College of Cardiology itself. Central to our mission, our values, and it really will help us take the very best care of our patients. Diversity and inclusion are essential to us achieving our goals, both in business and clinically, and additionally helping us to achieve our goals of being an educational resource to cardiologists and other professionals in cardiovascular care. But that change needs to be intentional. Right now, we are not a very diverse profession. And so we know that enhancing diversity will not be accidental. We can't do business as usual. We have to have a strategy, and we must be intentional with an unflinching commitment from our leaders, our members, and our staff. And our success, and we will be successful, will help us to reach our vision of optimizing cardiovascular care and outcomes for all of our patients. It's a part of our strategic plan. So the strategic goals and strategies of the American College of Cardiology are listed before you here. Number one is to increase the relevance of the college as a professional home for cardiovascular specialists. And key there is increasing member diversity and inclusion. And that will help us with the other pillars of our strategic plan, generating knowledge. That knowledge is more innovative and more inclusive and more thoughtful of underserved communities when we have diversity, advancing the quality and equity and value of care. We will be more able to achieve that if we have a diverse group of providers. And then finally, ensuring that, that our college and our profession will continue to grow and that our changes will be sustainable. We get closer to that, and that becomes easier if we are taking advantage of talent from all backgrounds. Increasing member diversity and inclusion will help us to be the #1 force for improving cardiovascular health in the United States and to help to do this across the world. But we're going to do that by integrating DE&I across our organization, and this includes all of our chapters. We're going to identify barriers because we know there are barriers to enhancing diversity and inclusion. What are they? Well, we must study them, write about them, and then come up with an action item list of how we can put our hands together and work. And then we need to ensure that our leadership, so we've got to be sure that when we look at our board of trustees, when we look at our leadership panel, when we look at our session leaders at our scientific sessions, that the diversity in our profession and in this nation is reflected. We can't do that alone. We need partners. So internally, we are very proud to have several years ago started a diversity and inclusion task force, which is now transitioned to a full committee. We now have a health equity task force. And we, throughout our education, advocacy, science, and quality missions, have diversity and inclusion as a foundational principle. But that's the ACC. We can't do this alone, and we need our external partners. And those are what we call all of our sister heart organizations, the American Heart Association, the Association of Black Cardiologists, and too many to name right now. We all work together, and we will need to lean on each other and to work together as we try to enhance diversity in the profession of cardiology. And at our heart, we are physicians who take care of patients, and we will need industry. We will need the producers of the tools that we use, the producers of the devices and of the pharmacological agents that we use to prevent and treat heart disease. So glad to be able to spend just a few moments with you today introducing this session. It's going to be an exciting session. We're so glad that you're with us. my partner, Pamela Douglas, the leader of our diversity and inclusion task force, and really such a tremendous icon when it comes to ACC thinking about diversity and inclusion. My good friend, Paul Douglas, who heads up our health equity task force. And then we're going to hear from our partners in industry, from Amgen, AstraZeneca, and Bristol Myers Squibb. So please, we look forward to working with you. We're so glad that you're joining us, and we hope you enjoy this session.
Hello, my name is Pamela Douglas. I'm the founding chair of the ACC Diversity and Inclusion Task Force and a past president of the ACC, as well as a faculty member in cardiology at Duke University. I'm talking to you today about a history of the American College of Cardiology's diversity and inclusion activities. Diversity and inclusion is an important goal for all of us because excellence and mission, fulfillment of mission, requires a richness of perspective and talent, which can only be achieved by having a diverse set of people at the table. Further, systemic or structural inequities exist which configure opportunity and assign worth based on certain characteristics like skin color or gender. These inequities unfairly advantage some individuals and communities and unfairly disadvantages others. These inequities are present in our current cardiology culture, our institutions, and our norms, as well as our interpersonal interactions, and weaken our entire community. Fortunately, they're amenable to modification and dismantling. Next slide. Why would we want to do this? Diversity and inclusion are important because they both help us to be better in many ways. As I've said, it helps us to access all available talent and expertise. It is also associated with more impactful and innovative science, education, and policy creation. Diverse groups of people make better decisions and improve strategic thinking. Diversity is also essential for us to address widespread disparities in healthcare and promote health equity, a significant problem for cardiovascular field. Finally, and not equally important, diversity and inclusion are necessary to create social justice and a level playing field. So our aim is a profession and a society in which all can thrive. Diversity is the metric, how we measure whether or not we have achieved this inclusion. At ACC, our goals are to ensure that we benefit from a variety of backgrounds, experiences, and perspectives in leadership, healthcare, business, education, and science. And to make that happen, we need to make sure that cardiology attracts and provides rewarding careers and leadership opportunities for the full range of talented individuals. Finally, we want to ensure that the diverse health needs of cardiovascular patients and populations are met by clinicians sensitive to and prepared to meet the unique needs of their gender, cultural, racial, and ethnic, and other dimensions of diversity. On the left, you see our infographic, which shows our approach. On the top, creating a culture of inclusion. In the middle, making sure that we engage and leverage talent from the deep pipeline through recruitment, retention, and ultimately to leadership. And finally, that we have accountable and durable execution through continued quality improvement initiatives. We want to build a strong foundation for DE&I and cardiology and embed it in the fabric of ACC. Culture change is essential to addressing system barriers and challenges, which will help us diversify the workforce, change the face of cardiology, and develop inclusive and diverse leaders. Importantly, to make this happen, we also need to communicate and celebrate diversity and inclusion, establish clear goals and directions, and stay connected with our members. Since this talk is about the history, here's our timeline. At the far left, you see in 2017, the task force was formed and began strategic planning with approval by the Board of Trustees in 2018. We immediately began engaging all aspects of the college, including chapters and committees, the vast majority of which have diversity and inclusion initiatives of their own. In 2019, we started the Clinical Trials Bootcamp training program, which has now nearly completed 2 cohorts supported by industry. Thank you, Amgen and BMS. We also wrote diversity inclusion governance principles, which are shown at every committee meeting for ACC. We published a paper with AMC on demographics in cardiology, and we published the first ever workforce health policy statement on compensation and opportunity equity. Moving on, in 2020, we started implicit bias training for the board and nominating committee, which has now gone to include the Board of Governors, and a train the trainer session earlier this year, which will eventually cascade out to literally hundreds of implicit bias trainers. We held the first of 2 stakeholder summits, getting together everybody in the field from national organizations to talk about the problem of the lack of Black men in cardiology. And we held a summit of CV Society's knowledge exchange with over 15 cardiovascular societies to share knowledge and best practices about diversity and inclusion initiatives. All along, we partnered with our program directors in cardiology, and they've published several surveys of diversity and paths forward. We're partnering this year particularly with the Board of Governors, asking each governor to work on the pipeline in their state and chapter and to mentor an undercoming year. Early in 2021, we launched a monthly webinar series, which is archived on acc.org. And just this past month in April, we converted to a committee under the leadership of Quinn Capers. So in summary, we need to work towards solutions, and we need to do this together. We need to acknowledge diversity and inclusion as a problem and spread awareness of its importance and how to fix it. We need to expand this beyond just simply representation. We need to make it a requirement for excellence and for achieving missions in all of our businesses and planning and programming. In particular, trainees, the future of cardiology, and leadership, our current policy and culture setters, are special cases. We need to focus on the entire community rather than just solely on the obviously underrepresented cardiologists, as people bring diversity and richness in perspective from many backgrounds. We need to develop deliberate quality improvement initiatives that are championed by leadership and supported by incentives, metrics, and transparency to address these issues, including individual bias and misbehavior, implicit bias, harassment, discrimination up to racism and sexism. We need to develop positive role models, mentors, and allies to help this effort. We do need to address structural injustice and dismantle any systems that disadvantage those underrepresented cardiologists, and incorporate diversity and inclusion in our climate and culture in all our strategic business decisions. Finally, we want to validate and share best practices so that all of us in all our societies and in all of our institutions can work towards this together. Thank you so much.
Hi, I'm Paul Douglas. I'm an interventional cardiologist with WellStar Health System in Atlanta, Georgia. And I would like to talk to you about the ACC's health equity strategy. As many of you may know, the history of health equity at ACC, the Board of Trustees asked us to develop and gave us a directive for developing a strategy to deal with health equity as it relates to cardiovascular medicine in 2020. The founding chair of this committee was Dr. Dipti Ishapura, our current ACC president. On the slide in front of you are the current members of the Health Equity Task Force. Our task force is comprised of a number of talented individuals, and certainly without their hard work and dedication, none of the accomplishments to date would have been possible. And before I go further, I want to certainly thank all of the members of the task force and appreciate very much all of the efforts that they have provided to help us achieve this goal. The ACC Health Equity Strategy created 3 goals, but we first had to develop a vision for where we wanted to go. Our vision was to achieve a culture of health where every person reaches their full cardiovascular health potential as a natural right. And we spent a lot of time discussing what that meant. And we came to the conclusion that everyone has a natural right to adequate and quality health care. And then we created 3 goals. One was to create a culture of health equity in cardiovascular medicine. The second was to prioritize health equity in all of the ACC activities. And then the third goal was to eliminate disparities by ensuring equitable cardiovascular care for all. And in order to achieve these goals, we developed 3 strategies. In order to create the goal of culture of health equity in cardiovascular medicine, we thought that it was important to execute change management to create a mindset that health equity is an essential component of quality cardiovascular care. And we spent a lot of time talking about that and what that meant to the college and to all of our partners with the college. We also spent a lot of time talking about the need to commit to cardiovascular equity, health equity principles, and to develop policies for action. And then finally, in order to create a culture of health equity, we thought that support in engaging our partners, other organizations that share our vision and share our commitment to achieving health equity would be extremely important. The second goal was to prioritize health equity in all of our ACC activities. And we thought that we would get there by embedding health equity in all of our educational curriculum, programming, and even in our guideline development, that this would be part of our strategy and priority. We also thought that providing clinical programs and guidance to identify and evaluate disparities and social determinants of health, that was a very important aspect and would help us in terms of achieving this goal. And then finally, we would integrate health equity into our compliance requirements as we look at the compliance that cardiovascular specialists have to meet, maintenance of certification, that we thought that these things too would be important and they should be integrated into our quest for health equity. And then the final goal that we developed was to eliminate disparities by ensuring that equitable cardiovascular care is delivered to everyone. And we thought we would achieve this goal by providing actionable data and tools that empower cardiovascular professionals. This would allow us to address health disparities and social determinants of health. We thought that this was an important aspect of our activities, especially in view of the fact that we have spent a lot of time looking and identifying health disparities, but now is the time for us to try to solve health disparities and to achieve health equity. We also want to partner with public and community stakeholders to ensure availability of resources for optimal patient care that eliminates all health disparities. And finally, in keeping with the mission of the college, we want to drive innovation in a way that it addresses health equity as well. And so these were the goals that we developed and the strategies that we have talked about as a task force to try to achieve these goals. And so our vision is to achieve a culture of health where every person reaches their full cardiovascular health potential as a natural right, to align our strategies with the overall ACC mission and vision. And then finally, and most importantly, to acknowledge the role that systemic racism plays in the disparities of health. I think that it's important for us to understand that racism in many instances undermines our ability to achieve health equity, and full acknowledgement of that fact will help us to overcome these systemic problems and barriers that prevent us from achieving health equity. And so we will want to try to create a culture of health where everybody has the opportunity to achieve the best cardiovascular health that they can achieve. We will want to prioritize our health equity strategies in all of our ACC activities. And finally, we want to eliminate disparities by ensuring that everyone has adequate quality cardiovascular care. And we're going to try to achieve these strategies by incorporating education, advocacy, science, and quality. The road to health equity, we think, as it relates to cardiovascular medicine, will go down those three pathways. And these are strengths of the college. We think that education is extremely important, of course, and we'll want to encompass all of our health equity strategies in all of the educational products and tools that the college has. Advocacy is an extremely important aspect of the college's activities. We'll want to empower the advocacy groups to go to our legislators, to the regulators, and advocate for health equity to try to remove those barriers that we know are responsible for systemic racism. And then finally, science. We have a tremendous amount of disparities data that has documented the disparities that exist in the delivery and implementation of cardiovascular care. We want to continue to innovate the science to help us understand these barriers and the social determinants of health that will allow us to break down these barriers and achieve health equity. I think that in order to approach this problem in a very strategic way, that we have to have all of these components in place that will help us achieve our goal. And then finally, let me say this. Many times prior to today, I think that we have looked at individual practitioners as the culprits, if you will, when it comes to health disparities and health equity. I think that it's important that we as a college now have a broader view and understand the systemic and institutional barriers that prevent us from achieving health equity. I think that it's important that we understand the social determinants of health and that we all, with our partners in academia, with our partners in industry, with our partners in government, and with our global partners, try to come up with strategies that help us to dismantle the systemic racism that has resulted in these institutional problems so that we can all achieve health equity and provide adequate and quality health care for all who live in our society. Thank you very much for listening to my dialogue. We look forward to partnering with you in achieving this most important goal.
My name is June Gang. I'm the Director for Diversity and Representation for Clinical Research at Amgen. At Amgen, we center our diversity, equity, and inclusion strategy around 4 key areas: people, culture, community, and sustain. We are committed to fostering a culture of belonging where diversity is celebrated and inclusion is the norm. This is central to our ability to thrive, and it is critical to operate as a team to serve our patients and to reduce inequities globally. We approach this ongoing important work by drawing inspiration from science. Continuous learning builds knowledge over time to drive discovery and innovation and ultimately create profound change. We believe our differences lead to better science, and that is embedded throughout our diversity, equity, and inclusion priorities and strategy development. To address success, we do measure success through the lens of equity by achieving sustained outcomes in all our employees, co-creating an environment where inclusion and a feeling of belonging is actually the norm. Ensuring we embed diversity, inclusion, and belonging in everything we do, including our business practices, policies, processes, and procedures. There is a high level of commitment and engagement of our leaders in proactively advancing efforts, both internally and externally, as we all continue learning and holding also the leaders accountable in sustainable outcomes. Now, when it comes to cardiovascular care, in addition to the overall diversity, equity, and inclusion at Amgen, we're also committed to lead from the front when it comes to narrowing the gap on disparities in health outcomes. The recent FDA drug trial snapshot released in November of 2020 highlighted the continuous underrepresentation of racial ethnic minorities in clinical trials, including trials in cardiovascular diseases. We have an internal team at Amgen called RISE, which stands for Representation in Clinical Research. And the main goal of this team is to lead our efforts to increase the proportional representation of the historically underrepresented populations in Amgen's clinical trials. As I mentioned, I'm part of this team. The cardiovascular therapeutic area is one of the areas we are focusing our efforts on amongst therapeutic areas. We believe improving the enrollment of these underrepresented populations in cardiovascular clinical trials would contribute towards our efforts to reduce disparities in health outcomes and also address some aspects of diversity, equity, and inclusion. So in terms of how we could partner with organizations like ACC, numerous studies have characterized the social determinants of health and the associated disparities in health outcomes. At Amgen, we acknowledge that the journey towards health equity for all is long and arduous. And despite challenges, we remain on the path of progress. And for us to stay on that path, we will need significant collaboration and partnership. In order to ensure equity, the patient and the patient's ecosystem should be front and center when coming up with strategies. ACC is a great advocate, not only for the profession, but also for patients. And there is opportunity for ACC and other organizations to partner with the life sciences industry in championing sustainable efforts towards addressing the issues within the healthcare ecosystem. We would like to emphasize the need for these efforts to be sustainable rather than transactional. Sustainable efforts, we believe, will establish relationships that will help build and maintain trust with all patient populations.
Hello, everyone. First, I want to thank all of those who helped organize this event. I'm truly honored to be here and also very grateful to the American College of Cardiology for their commitment to diversity and inclusion in hosting this summit. I'm Chris Berner, and I'm the Chief Commercialization Officer at Bristol Myers Squibb. As a company, BMS is deeply invested in advancing diversity, equity, and inclusion across all aspects of our business, and that includes cardiovascular disease care. We understand the extent to which health disparities disproportionately affect underserved communities, putting them more at risk of severe diseases. Addressing these inequalities requires all of us in the healthcare system to stay laser focused on meaningful change. And at BMS, we are committed to doing our part to help improve health outcomes for those patients. This is core to our company strategy as we advance our vision of transforming patients' life through science. We're actively engaging with our workforce, partners, suppliers, and communities to drive innovation through a D&I and health equity lens and mindset. We know our company is stronger when our workforce reflects the diversity of our patient population. We're making significant changes in the way we operate our business through 4 pillars of our D&I strategy. First, we're setting aspirational goals to increase the diversity of our executive population. Second, we're accelerating momentum with our people and business resource groups with full-time dedicated leaders. Third, we're shaping the culture of inclusion. And fourth, we're driving external relationships with purpose by building a robust STEM pipeline. In August of 2020, BMS and the Bristol Myers Squibb Foundation each committed $150 million to advance diversity and inclusion and health equity efforts across 5 focus areas: addressing health disparities, increasing clinical trial diversity, expanding our supplier diversity, increasing executive workforce representation, and increasing employee giving to organizations that fight racial discrimination and health disparities. The commitments reflect our dedication to being an inclusive, patient-centered company that responds to the growing diversity of patients facing cardiovascular disease. We know our science and innovation have to reflect that diversity. BMS is well-positioned to significantly improve outcomes for populations impacted by the diseases that we treat, including cardiovascular disease. This is part of a long-standing commitment to cardiovascular disease. It began more than 60 years ago, and it continues today. We're currently evaluating multiple novel agents that treat serious cardiovascular condition. There's increasing evidence that cardiovascular disease disproportionately impacts underserved populations. Take stroke risk, for example. It's nearly twice as high for Black and African Americans, who also experience the highest rate of deaths due to stroke. Through our health equity grants, we are supporting organizations such as the DC Black Church Initiative and Mended Hearts to provide community-level prevention and disease education. We are also designing and implementing broad-reaching, culturally competent disease awareness and education campaigns. A campaign I'm incredibly proud of is No Time to Wait. This is a bilingual campaign directly addressing a major issue: the sharp decrease in patients seeking medical care as a result of the pandemic. How are we doing it? By raising awareness through among high-risk populations about why they need to see a doctor when experiencing AVIB and DVT symptoms. And we also understand that to create long-lasting change, we must increase diversity among those who design, lead, and conduct our research and development. The reality is that cardiologists lack gender diversity. Just 9% in the specialty are women. It's clear the global talent pool needs to be expanded to ensure that the benefits of greater diversity are realized. And this is why we've supported the ACC's effort to provide women cardiologists with more professional and leadership opportunities. It is a privilege to be part of this work, and together with so many of you, we embrace our roles in advancing diversity and inclusion and health equity. I'm pleased to introduce my colleague, Dr. Samit Hirawat. He's a physician by training and is BMS's Chief Medical Officer and Head of Global Drug Development. With his experience as a physician and more than 20 years of experience leading drug development across therapeutic areas, he understands firsthand the importance of increasing clinical trial diversity.
Hello, everyone. I hope you're all safe and healthy. I appreciate everyone joining us virtually, and I look forward to a day very soon when we can be together in person. In order to ensure our research and science are inclusive and reach underserved populations, we must begin with improving clinical trial diversity, as Chris said. right now, Black or African American people represent approximately 13% of the US population, yet only make up about 5% of participants in the clinical trials. And this disparity is even greater for those of Hispanic or Latinx origin, who represent about 18% of the US population by census, but only 1% actually participate in clinical trials. And the main goal of BMS's efforts to increase diversity in clinical trials is to recruit more diverse participants in these studies, patients that reflect both the demographics of the real world and represent the epidemiology of the disease that we're trying to treat, which can differ between races. Now, while we must focus on more effective community outreach and engagement, we also have to pay attention to the clinical trial infrastructure in itself. Who are the investigators? And where are the trials being run? As part of our commitment to clinical trial diversity, BMS will ensure that 25% of all of our clinical trials for new clinical trials that are starting in this year itself will be located in racially and ethnically diverse metro areas with more than 30% non-white population. We're also proud to support ACC's Campaign for the Future, which is designed to both diversify cardiology researchers and include more diverse patients in future cardiology research. Now, there are many factors and burdens that prevent diverse clinical trial participation. Education and awareness, site accessibility, language barriers, lack of trust, unconscious bias, as well as range of socioeconomic factors. Efforts to increase diverse participation in clinical trials must include elements that address all of these barriers. At BMS, we focused on 4 long-term areas of study: awareness and communication, clinical trial data, patient and caregiver materials, and site selection. The first focus area, awareness and communication, will raise critically needed awareness of BMS's progress in diversity, both internally and externally. Second, clinical trial data will allow us to consider the development of our trials from study design to execution that impact diverse populations. Third, we will ensure our patients and caregiver-facing materials are tailored to the specific populations we aim to treat. And finally, the development of a site selection strategy will align our trials with the epidemiology of the diseases being studied. These efforts all support our commitment to effect sustainable change and maximize impact, delivering better science and hopefully better outcomes for our patients. Of course, there's still so much more to be done. We know how much transformation and collaboration is needed to create lasting change. We also know that succeeding in these endeavors will require all of us to take bold, deliberate actions with our organizations, and most importantly, together. BMS is committed to helping driving that change alongside each and every one of you, because ultimately, patients, all of our patients, are counting on us. Thank you.
Hi, everyone. I'm Martha Orzechowski, and I'm here today on behalf of AstraZeneca. Thank you so much for the invitation to join you. One of the things I'm most excited about as AstraZeneca is that we have really taken inclusion and diversity on as a priority for our organization. And we're doing that in 2 different ways. The first way is what we call our contribution to enterprise. And as part of that work, we've named a US head of inclusion and diversity who is looking after how we as AstraZeneca build an inclusive culture and foster diversity within our 4 walls at AstraZeneca. So the contribution to enterprise piece is really about how we work, and do we as a company reflect the patients and the communities that we serve, and what are we doing to continue to build that inclusive and diverse culture at AstraZeneca. So that work is well underway under our head of inclusion and diversity. And we look forward to sharing more about our progress there later in the year. The second piece of the work that we are looking at is what we call our contribution to society. So this is how are we as AstraZeneca engaging with the external world on an inclusion and diversity agenda. For that piece, one of the primary things that we are looking at is the topic of health equity and what is our role as AstraZeneca in contributing to progress in that space. And so to that end, we've launched a program this year, a 5-year program that we are calling Act on Health Equity, which stands for Accelerate Change Together. And what it means is exactly that. It means we as AstraZeneca know we have a part to play, but we also know that we can't do it alone. We will need to bring other people, voices, organizations to the table to build that 5-year roadmap. As part of the Act on Health Equity program, we do have 3 main pillars where we will focus. One is the piece about external insight. We don't know what we don't know, and we are not health equity experts. And so we as a company are prioritizing and recognizing that external insight is going to be a key part of informing where we go from here. And so we will regularly talk to external experts on health equity. We will regularly talk to the ACC and other organizations about the work that you're doing and the perspective that you bring. And we will take all of that and reflect it in the plans that we make for the next 5 years. The second piece is what we call strategic collaborations. And this is how are we building a health equity lens into the collaborations, partnerships, relationships that we already have with the nonprofit community. So partners like the ACC, how are we putting a health equity lens on the work that we do with you? How are we ensuring that as we work together to tackle issues that are important to patients and providers, that we center health equity in all of those collaborations? And the third pillar is employee engagement. Our employees are so excited about health equity and inclusion and diversity, and they want to get involved. And so we will put an emphasis and a focus on how we can involve our employees in the work that we're doing in Act on Health Equity. Part of that will be done through our Power of Us program, which is AstraZeneca's matching and employee volunteerism program. And we will look to highlight organizations that are making a difference on health equity through that. We will also work with our partners as appropriate to identify employee volunteer opportunities where they can work on projects related to STEM or health equity. But we think there's going to be a lot of great work that will come out of it, and we want to take advantage of the fact that our employees are so enthusiastic and harness that enthusiasm to continue to do more good. Over the next 5 years, one thing is certain, and that is that we are going to learn a lot, and we are only at the beginning. We're very excited to learn, and we're very excited to act. One example I can give specific to the cardiovascular space is absolutely ACC's efforts in health equity and specifically Campaign for the Future. AstraZeneca is very excited to be a supporter of this work, and we look forward to seeing the progress that the ACC and partners will be able to make to really ensure that the pipeline for cardiologists is diverse and reflective of the diverse communities that we live, work in, and that patients and providers live and work in. In addition to what AstraZeneca does as a company, we're also very proud of the AstraZeneca Healthcare Foundation, which is a separate nonprofit entity also based here in the US. And this foundation has long been committed to health equity. The foundation was started in 1993 and has done work in oncology and done a lot of great work in cardiovascular. Most recently, the foundation has supported a program called Connections for Cardiovascular Health. And in that program, the foundation gives away money to nonprofits who are really working at grassroots community level to improve the health of individuals in communities. One example that comes top of mind is Mallory Community Health. They're a grant awardee based in Lexington, Mississippi, who focused their program in on tackling obesity. Their target audience was low-income African-American women, and through the build of a robust program that included addressing nutrition, exercise, and many other pieces, 63% of Mallory Community Health participants were able to reduce their A1C levels and live a healthier life, which is good for them and good for their communities. In closing, I have to tell you that there is a lot of work to be done in health equity, and the only way that we can really make significant progress is to come to the table together. AstraZeneca can't do it alone, ACC can't do it alone, and neither can any of our partners. And so let's continue to hold hands on this issue. Let's continue to learn together, and let's continue to strive to close the gap in healthcare disparities so that we can ensure that patients, all patients, are receiving everything that they need to achieve the best possible outcomes. I'm convinced if we work on this together that we will make progress. Thank you so much for inviting me to speak today. I look forward to hopefully a day sometime soon where we can all be together in person. And in the meantime, good luck on your health equity efforts. We look forward to being a partner as we go on this journey, or even more exciting, this adventure together. Thank you so much.
Thank you so much for joining us. This would not be successful without your participation. And I want to thank, of course, our speakers from our industry partners and our ACC speakers. It's been a great session, and I hope that you've taken something from this that you will take back with you. Please reach out to us, reach out to our partners. We are one together, and again, we won't make progress unless we're all working together. I hope you enjoy the rest of our 2021 ACC scientific sessions.